je vous propose qu'on commence sans attendre cette nouvelle session. En principe, c'est une session qui est intitulée méthodologie et éthique. Donc évidemment sous-entendu dans les pratiques des INM ou dans le modèle porté par la NPIs. On va accueillir cet après-midi une belle brochette d'intervenants. Ça va être diversifié, très intéressant, pour donner des éclairages différenciés justement sur ces approches méthodologiques et sur ces réflexions éthiques. Et on va commencer par le professeur Kim LAVOIE. Je ne sais pas, elle était là il y a 2 minutes. Ah voilà, ok. Donc, qui est professeur au département de psychologie de l'UQAM, l'Université du Québec à Montréal, et qui est co-directrice du Centre de médecine comportementale de Montréal. Elle est donc spécialiste des sciences du comportement et va nous parler, nous proposer une réflexion de cadrage sur les enjeux méthodologiques et de définition des INM. Merci.
Bonjour tout le monde. Hi everyone. Bien que je suis complètement bilingue, ils m'ont demandé de présenter en anglais, bien que je trouve ça bizarre. Ça se peut que j'utilise un peu de franglais, mais si jamais il y a des questions, un peu comme la présentatrice d'hier, ça me fait plaisir de prendre des questions en français. But yeah, so that's what I'm going to do. I'm going to try not to talk too fast, because I can talk very fast. So let's make sure this works. These are mes disclosures, mais il n'y a rien en lien avec la présentation. There's nothing related to the presentation. Listen, it's really a pleasure to be here, and I want to thank Greg and the organizing committee for the invitation. I've been working with Greg for many years now, working to bring better methods, better evidence to behavioral interventions, NPI interventions, both here in France and Canada and around the world. What a passionate audience we always have. I love that it's so multidisciplinary. We have medicine, public health, psychologists, dietitians, kinesiologists, nurses, so many specialties interested in one thing, and that is how do we support people and societies and communities to make better decisions about their health. So that's what I'm going to talk to you about today. I'm hoping to give you some concrete tools that you can use to improve some of your methods around bridging the gap between evidence and implementation. So, by the end of this presentation, we're going to actually start by defining what we would consider to be a behavioral intervention, and how that might be a little different than an NPI, but there's some overlap there. Define implementation science and the advantages of adopting what's called an integrated knowledge translation approach, which engages all key knowledge users, tous les parties prenantes clés, from the beginning of your research through to the end. And as I mentioned, what are some of the methods and key tools we can use to engage knowledge users in our research to improve implementation success, excuse me. And I'll be using the term behavioral intervention rather than NPI, because all behavior interventions are NPIs, but not all NPIs are behavioral interventions. And we can talk about that. We're still debating what terms we should use and so on. So maybe that'll be part of the discussion a bit later. Okay, une question pour vous, pour commencer, a question for you all. True or false? Vrai ou faux? Blood pressure, cholesterol levels, and glucose levels are pharmacological interventions. Qui pense oui, c'est vrai? Raise your hands. Qui pense no? Raise your hands if you think it's false. Right. Excellent. Of course not. We would all agree that these are targets of pharmacological interventions. These are not pharmacological interventions themselves. Another question, true or false? Exercise, smoking cessation, and weight management are behavioral interventions, or NPIs. Raise your hands if you think true. Raise your hands if you say false. Okay. I'm going to blow your mind, all right? This is false. These are actually the behavioral targets of behavioral interventions. They're the equivalent in our terms to blood pressure, cholesterol levels, and glucose levels. What are behavioral interventions? And I want us to increasingly try to think of it this way. And I think it's going to help very much with our definitions and a terminology that we use. Think of behavioral interventions, or NPIs, as what we are doing as interventionists or policymakers to get people to adopt healthier lifestyles. It's what we are doing that's the intervention, not what we're aiming for patients or populations to do. Ça va? All right, so what's a behavioral intervention? It's usually a collection of fully reducible behavior change techniques, des techniques de changement comportemental, informed by usually research in behavioral and connected sciences that are designed to modify processes important for changing human behavior. And this is the definition of behavioral science. It's multidisciplinary, but typically we find research and knowledge and tools from psychology, sociology, economics, anthropology, epidemiology. Okay, it's a very multidisciplinary field, and the ultimate goal is to understand, explain, predict, and influence behavior, whether on an individual or a population level. Okay? So 2 tools for, if we agree that an NPI or a behavioral intervention is usually a lot of other things. It's a plusieurs composantes that we're going to put in our behavioral interventions. These are 2 tools that might help you select what behavior change techniques you're going to put into your intervention packages. There's on the left Susan Mickey's behavior change technique taxonomy, and this is an interactive tool. If you go to the website, you'll come upon the article, and you can click on the article, and it's going to bring you to this lovely page in the supplement. You click on every single technique, and it'll give you a definition and examples. So it's an interactive article. And the panel on the right is the Behavior Change Theory and Techniques tool. And what this does is it gives you a sense of the levels of evidence for each behavior change technique and their mechanisms of action, leurs mécanismes d'action. La technique est à gauche et les mécanismes d'action c'est en haut. And this is also interactive. So these are 2 fantastic tools that might help you figure out what you need to put in your intervention. So when should you consider designing and testing a behavioral intervention or an NPI? Well, I think it's when you've identified a clinically or socially significant problem that you think a behavioral solution could solve. It's not for everything. It should be a clinically important or socially important problem. It could be crime and violence. It could be mis and disinformation. It could be lack of physical activity and smoking. Could be behaviors related to climate change. Okay, so the behavioral solution has to be reasonable and aligned with the problem you're trying to solve, and we're hoping it's going to be an important one. And I think we would agree that most major global challenges right now involve changing human behavior. So chronic diseases, many of us work in these fields where we're trying to prevent chronic disease through greater engagement in physical activity, better diets, smoking cessation, and so forth. And all those behavioral targets are important risk factors for every single chronic disease facing us today. The COVID-19 pandemic, that really kind of raised awareness, I think, for the importance of behavioral sciences and insights. How do we mobilize a population to do a whole bunch of behaviors that we weren't used to doing? Some of those behaviors were also very costly. Ça coûtait beaucoup because they were hard to do, because they involved making sacrifices. How do you get everyone to band together across the world to adopt these incredibly important prevention behaviors? And I don't think anyone would disagree that climate change, okay, which has been identified as one of the most important, perhaps, global health challenges in the history of humankind, it's going to involve changing human behavior related to consumption, related to transportation, related to agriculture on a global scale. We need to help support people to make different decisions, and industries and politicians to make different policies to help with this climate crisis. And at the end of the day, we're talking about changing individual, community, society behavior, but also the behavior of politicians and decision makers. Okay? So how should you go about designing and testing a behavioral intervention? Well, I'm here to talk a bit more from the perspective of implementation science, okay? And all behavioral and NPI interventions should be designed with implementation in mind, okay? And that's from the perspective of all relevant knowledge users. Tous les parties prenantes qui sont pertinents pour s'assurer le succès de la mise en œuvre de votre intervention. So I'm going to share something that many of you may be familiar with, which is the APIs framework. Now, APIs is a framework that comes from the Behavior Change Wheel, which some of you may be familiar with, that comes from Susan Mickey and colleagues at University College London, and it's used to assess the feasibility and potential success of an intervention. There are 6 criteria that you need to think about when you're designing your intervention. Think about the end in mind, okay? You need to think about acceptability from the perspective of the people who will do the intervention, from the perspective of the people that will deliver the intervention. How practical is it? Can it be delivered in your healthcare system? Okay? Can it be scaled to the degree to which it needs to be scaled? Is it effective? So this is classic efficacy research. Does it achieve its intended outcomes? Is it affordable? Okay, so I always say it's useless to design the Rolls-Royce of behavioral NPI interventions that no one can afford to pay for or no system can afford to reimburse. So you have to think about that when you're designing as well. You want to think about doing no harm, so any unnecessary sort of spillover effects. And you want to make sure that in your design, you're not actually creating any inequities, unequal access. So for example, we've talked about digital interventions. Well, to be able to access a digital intervention, you need digital literacy, you need access to the internet, and you need some connected device. And we all know that everybody around the world doesn't necessarily have equal access to these things. Okay? So who are the primary knowledge users of our interventions? There are many, and you need to be thinking about all of them when you're designing your interventions. We have other researchers who are going to inform our interventions, collaborate with us, help us strengthen our interventions. There are the patients or the public that we design our interventions for. They're the folks who are going to benefit from our interventions. Healthcare providers, the multidisciplinary providers who are going to deliver our interventions, the administrators or the systems that are going to offer them, and of course the policymakers and governments that are going to ultimately pay for them, particularly in systems like in Canada and in many places in Europe where we have universal or publicly funded healthcare systems. So you need to think about all these knowledge users, and you need to think about engaging them early in your intervention designs. So when and how should you integrate these different knowledge users and perspectives early and often, okay? All relevant knowledge users should be part of your research program from day one. And they should also help you formulate your research questions, intervention designs, and your implementation plans. And if you do this early and often, you'll often you'll fail early, okay, and that sounds like a terrible thing, but you want to fail early in these early phase studies, not when you have a fantastic intervention that no one can do and no one's going to implement, okay? And keep in mind that each knowledge user will have different expertise and have different, we'll say, research or outcome priorities, okay? So researchers were primarily concerned with designing and testing the intervention, and so we're primarily concerned with efficacy. Does it work? Okay? Does it help people lose weight? Does it help people become more physically active? Patients or the public, are the ones who are going to receive the intervention, and they're often most concerned with accessibility, acceptability. Is this something that I can do? I can fit into my daily schedule. Healthcare providers are those who are going to be delivering the intervention, so it needs to be feasible for them. It needs to be able to be integrated fairly easily into the current system. There are healthcare administrators who will implement the intervention, and so they're concerned with the practicability and scalability. And finally, government and policymakers who are going to pay for the intervention. So they're looking at outcomes related to cost effectiveness. So when you're designing a research program, you need to think about these are different outcomes and they're implementation outcomes. Only one of these is efficacy. Does it work? And all the rest are going to help you generate an evidence base for how do we go from efficacy to implementation. All right, so how do you do this? I'm going to say by adopting an implementation science approach. So what is implementation science, and what frameworks can you use to guide your choice of integrated knowledge translation methods? Okay? So what is implementation science? It's the scientific study of methods aimed at promoting the systematic integration of research findings and evidence-based treatments into health policies and practices to improve quality and effectiveness in real-world settings, okay? The objective is very specific, to identify factors, okay, that affect the adoption of interventions or treatments in practice, and we want to intervene on those factors. It's not to establish the impact of the intervention on health. That's efficacy studies. Implementation studies or implementation trials look at those different factors that are related to how can I get this into practice once I've already demonstrated it works. Another way of looking at implementation science, and this is a slide I borrowed from a colleague, Justin Presso, who's done fantastic work in this field in Canada. The intervention, the practice, the innovation, the treatment is the thing, c'est la chose. Effectiveness research looks at whether the thing works. Est-ce que la chose fonctionne? Implementation science looks at how best to help people and organizations do the thing. Okay, faire la chose. Implementation strategies are what we do to help people and organizations do the thing. And implementation barriers and facilitators are what strategies act on to help people and organizations do the thing. So key implementation outcomes are to what extent and how people and organizations do the thing. Ça va? All right, it's hard to see. I'm going to share a framework, the Consolidated Framework for Implementation Research. Who has heard of this? Qui a déjà entendu parler de ça? Quelques personnes? Okay, deux, trois. It's a start. So this is one of the most widely used frameworks that we use in Canada, and it's pretty popular elsewhere, I think. And it looks like this. It's a bit busy, so I'm just going to take you through it. These are things that you should assess ahead of time. So we have things like, from the APIs framework, things like acceptability, appropriateness, and feasibility. So these are things that you want to assess ahead of time. Your anticipated implementation outcomes are the things you need to design for. Il faut concevoir vos interventions en fonction de ces caractéristiques-là. The adaptability, implementability, and sustainability. You need to design for these variables. And then you have to, once you've done that, assess it. Make sure that your intervention is being adopted. It's being implemented as designed. And it's sustainable over the long term. A lot of interventions get implemented in a few centers. There's no surveillance, there's no outcome evaluations, and then it drops off. So we need to understand how we go from efficacy to implementation. There's hurdles to overcome. You can't implement the same way in every site. So this requires another level of investigation. And you know that you've innovated when the people in practice are doing something different. Les intervenants sont en train de faire des choses autrement en pratique. Your key decision makers are making new decisions, different decisions about health and healthcare policies. And the people that are receiving the interventions are doing better. Okay? So that's how you know you've innovated, is when you've changed practice. So identifying the determinants of successful implementation using this framework, this is just a way to use the model. So you need to specify the area of intervention or innovation that you're working in. So how and where your intervention is going to make a difference. So what's the added value? What's the benefits, the design, and so forth. Maybe it's going to be something that's going to be cheaper and more effective than what exists currently. Then what are the factors associated with the external environment? What needs to be considered for you to implement that intervention in practice? Making partnerships, policies and laws need to be enacted. Factors associated with the internal environment is what needs to be put in place to support implementation at the sites, at the level of healthcare delivery. So what are the structural characteristics, l'infrastructure, the information technologies that might need to be put in place? Factors associated with individuals, so who needs to advocate for the implementation and what do people need to succeed? So you might need to train your healthcare workers to actually deliver your intervention. Well, that's another step. That's not the intervention efficacy. That's training your people on the ground to be able to deliver it at the sites and the locations in which it's going to be delivered. And the factors required for successful uptake are what skills and competencies need to be strengthened in your workforce. So you might need team building. You might even need to convince your healthcare workers that this is a good thing to do. Ça va? So how do you measure the success of implementation? Falco gave us a great introduction to this yesterday, and this is the REAIM framework. So I'm going to go into a little bit more detail. He had a few slides on it, but I'm going to give you a few more details. So REAIM is a set of measures of interventions or program elements that can improve the sustainable adoption and implementation of effective, generalizable, and evidence-based interventions. There are essentially 5 things that you can measure. The reach of your intervention in your target population, its effectiveness or efficacy, does it work? The adoption by your target staff or healthcare workers or your system or community, the implementation consistency, costs, and adaptations made in delivery, and maintenance or sustainment of intervention effects over time in your settings of implementation. And I'm going to give you some concrete strategies on how to do each one of these things. Okay, so reach. This refers to how many people you were able to reach with your intervention. Okay, how many are willing to participate in the intervention or the program. So some of the strategies that can increase the reach of your interventions in practice is building relationships with your target population. I never design an intervention that doesn't start with having my target audience, my target population, at the table with me co-designing. On parle souvent de la co-design ou la co-conception ou la co-construction. This is critical now, because who am I? I'm not the expert. The patients or the communities are the experts. I need them at the table at the design phase. I often get them to help with recruitment, because they'll know the challenges associated with coming in for research or with the protocols that we have. They'll be great sources of ideas and information about how can we include people in our research. Another thing that that's going to improve your reach is bringing your interventions to your patients or your populations. This was done beautifully during the COVID pandemic. Rather than bring people into central vaccination sites, we went into communities. We brought the vaccines to community pharmacies. And this was one way that enabled people to uptake the intervention, in this case, vaccines. So that's one of the critical ways we increase reach. Effectiveness. This is something that we all know a lot about. I'm not going to go into too much detail, but it's the impact of your intervention on our outcomes of interest. So my bias, and it's my bias, is that intervention components should be theory-informed and evidence-based as much as possible. And that is, if you design an intervention with 5 or 10 components, BCTs, you should be able to map how you think it's going to work. What are the mechanisms of action that the education is going to have, that the skill building components are going to have? And in your trials, you should be measuring, is your intervention working as you expected, as you designed, okay? You want to engage your community organizational partners early, and you want to solicit ongoing feedback as you go. So even though you might have an effective intervention, there may be things that your populations, your participants, can give you feedback on for further refinement. It's not a done deal, and particularly in digital health, we talked about this yesterday. The advancements are so quick, it's hard to keep up. So it's a constant feedback loop. Okay, so we're constantly feeding back to improve our designs and streamline our interventions. Adoption is the absolute number, proportion, and representatives of settings and interventionists who are willing to deliver the program. These are your nurses, your psychologists, your kinesiologists. I recently evaluated a grant which relied upon midwives doing an intervention with pregnant mothers. Wonderful study, wonderful intervention, but the problem was, for it to have true impact, you needed a certain number of midwives available in Canada to deliver it, and we didn't have it. So I struggled because I was almost forecasting a gap in implementation because we just didn't have the efficacy in the skilled service delivery providers. So what do we do with that? We need to keep those things in mind. It's great to have an intervention that works, but if we can't deliver it, then it's not going to impact practice or health outcomes. So you need to understand the context in which you're designing your interventions. Who's going to deliver it? What kind of extra training are they going to need? You need to engage your organizational decision makers. If your intervention's new, how easily can it be integrated into existing systems? And you need to collect data as much as possible that shows that you can reach people and that it's easy to integrate into current systems. And that requires an evidence base as well. Implementation, and this basically refers to, can your delivery providers deliver your intervention as you designed, as it was intended, okay? And this is critical and something that's a critical outcome to evaluate in implementation research. It's one thing to show efficacy under controlled conditions in a trial. It's very different when it's out there in the real world. And we see a lot of gaps between efficacy and implementation because we didn't prepare our workforce to deliver our interventions. So pilot test with a small number of providers to determine feasibility, figure out what needs to additionally be offered in terms of training or skill building, and of course provide support, whether it's infrastructure, materials, additional training. Sometimes that's the frustration. A lot of providers resist adopting new interventions or integrating them in practice because they don't feel supported to do it. We saw a workshop with Vera Suarez this morning, surprisingly another midwife intervention, where there was resistance to implement evidence-based guidelines around smoking cessation in pregnant mothers, not because they didn't agree or weren't motivated to do it, but they didn't feel they had the tools and the infrastructure support to deliver it. Something I hear from doctors a lot is, I love counseling for behavior change, but I don't have time, or I'm not remunerated to have those conversations. Fair enough. So we need to think about these things if we really want to improve this efficacy implementation gap. Finally, to what extent does a program or policy become institutionalized or part of the regular organizational practices? So as much as possible, you want to see how your intervention can fit into existing practices, align your intervention with what the mission of those organizations is, provide ongoing training and support because it's not a one and done, and be prepared to adapt your intervention for different contexts, of course. I'm going to end with sharing a tool. This is all about engaging all those different knowledge users. It's called the Knowledge Translation Planning Template. There's a website here that I want you to take a photo of, and it's on every slide. I'm not going to go into detail on this tool, but it gives you a nice template to work with to figure out who do I need to engage, in what way, when, and how. Okay, so goes through knowledge users, main messages, goals, knowledge transfer strategies that you can consider, okay, for both, to inform the research, to facilitate policy change, and then at the evaluation phase. So it's just a guide. I'm not going to go into, I don't have time to go into it in detail, but please, it's available free of charge for download, and it's available in English, French, Spanish, and I think Portuguese, si je me trompe pas. All right. Budget items, very important. So it's a huge bridge to gap. It's a major challenge. These are some other resources that you could also check out. The Office of Spread and Scale in Toronto is a fantastic hub of expertise in this area. Please copy these websites. They're great tools to inform your implementation research. The take-home messages, as I mentioned, behavioral interventions are needed to solve some of the world's most important problems. We need to adapt our methods for design and implementation. Think about implementation at the beginning, at the design phase. Interventions are what we do with people. They're not the targets of the interventions, although we sometimes talk about them like that. Engage with all relevant knowledge users early and often. Innovations don't implement themselves. We need to come up with plans early to ensure that we have less of a gap between efficacy and implementation, and we must do better. And hopefully I've shared some tools that you can use in your own research. I think most of you have seen this already. If you like methods for doing this work, consider joining us in Montreal next May for the International Behavioral Trials Network meeting. It's full of workshops and plenary sessions with international experts. I want to say thank you so much for Greg for this incredible invitation, and I'm always so happy to be here to talk to you all. Thank you as well to Iveta Nagyova, our honorary president, and a fierce defender of this work. And of course, thanks to all of our funders and staff and students at the Montreal Behavioral Medicine Center who allow me to be here today. So thank you.